In Malaysia, there are airborne outbreaks such as the hand, foot and mouth disease, the anthrax scare, SARS or severe acute respiratory syndrome, avian flu and the H1N1 influenza virus. The question is, are we prepared with an effective surveillance plan and an efficient outbreak response to contain the infection? As surveillance is to systematically collect information on a specific disease or other health-related events, to utilize them for prevention and control, this data collection must occur on an ongoing basis with sufficient accuracy and completeness. Through surveillance, we are able to detect new health problems, detect a potential epidemic, document the spread of disease, give a prediction on the magnitude of morbidity and mortality for certain cases, describe the clinical course of a disease, identify potential factors in a disease occurrence, facilitate researches and in assessing control activities. Surveillance activities, as shown on the flowchart on the right, must be undertaken routinely at all levels. The extent and degree of the surveillance activities will depend on the type of infectious diseases, as specified by the respective infectious disease prevention and control programs. In the Ministry of Health Malaysia, surveillance is divided into 5 aspects, which is the laboratory-based surveillance, the mandatory notification diseases surveillance, clinical-based surveillance, community-based surveillance and other agencies. The mandatory notifiable disease surveillance is a disease notification system using an electronic information system. The laboratory-based surveillance reports the prioritized microorganisms, such as Vibrio cholera, Haemophilus influenza, Salmonella, Neisseria meningitidis and Leptospira, in all laboratories in Malaysia to the relevant health authorities. The clinical-based surveillance includes the surveillance of acute flaccid paralysis, conjunctivitis, and acute gastroenteritis on a national basis, hand, foot and mouth disease on a sentinel site basis, and 5 acute syndrome, namely acute jaundice syndrome, acute neurological syndrome, acute respiratory syndrome, acute dermatological syndrome, and acute hemorrhagic fever syndrome. Other agencies such as Department of Veterinary Services undertakes zoonotic disease surveillance, while the surveillance in foreign workers are being done by a private company called FOMEMA. Community-based surveillance includes the monitoring of rumors and reports on infectious disease from the community and media both nationally and internationally. The surveillance activities must be undertaken routinely at all levels depending on the type of infectious disease. The district health office or entry point is responsible for the surveillance of any airborne infectious diseases in the district, and must establish a system to routinely collect data from health clinics, general practitioners, clinic, hospitals, and microbiology laboratories. The data must be submitted according to schedule in a timely manner to the state health office. The medical officer of health will be responsible for collating, analyzing, interpreting and disseminating the information for action by relevant personnel in the district. For surveillance in the state level, the State Health Office is responsible to collate, analyze and interpret the surveillance data for trends and patterns of airborne infectious disease in the state. The State Health Office must submit the state data and information according to the schedule in a timely manner to the Disease Control Division in the Ministry of Health Malaysia. At the national level, the Disease Control Division is responsible to receive surveillance data from the state health offices, laboratories and reporting physicians. Then, the data would be compiled, analyzed and interpreted to detect trends and patterns of disease outbreak on a national level. Other than that, the surveillance at national level will also be responsible in monitoring press and other media reports both nationally and internationally to take appropriate actions when necessary. Sentinel surveillance involves systematically collecting data on a routine basis from a limited number of surveillance sites. Ideally, the sites are chosen to be representative, so that the information gathered can be applied to the population as a whole or, in certain instances, among subpopulations at higher risk of developing certain airborne illness. Sentinel surveillance is the most efficient way to collect high-quality data in a timely way. A sentinel surveillance system reduces the number of resources required, as efforts can be focused on a limited number of carefully selected surveillance sites. A sentinel surveillance system provides both the means to monitor the course of the epidemic and a tool to assist in the evaluation of the impact of interventions. Monitoring the course of the event in terms of numbers of admissions or other surveillance indicators will allow health professionals to know when cases are increasing, when the event has peaked, whether interventions are having an impact, and whether changes have occurred in the behavior of the virus. In the beginning of an outbreak and periodically throughout, there are key questions to ask, such as how different is the virus from the previous ones, is the community transmission sustained, what is the proportion of severe cases, and where is it occurring, who is most vulnerable, and what are the clinical features of the disease. Once the questions are answered, we will be able to make implications-related decisions and recommendations regarding the outbreak. An example of surveillance of an airborne disease like tuberculosis is as follows. As soon as a person is diagnosed with tuberculosis, the case is registered with a central registry followed by the nearest clinic and the supervising doctor. The patient's progress, like the completion of treatment and recovery, is again notified. From the tuberculosis case, we can use several indicators to evaluate the control of tuberculosis, like the annual rate of new tuberculosis cases diagnosed in terms of symptoms, age, examination, and the relapse rate. In the Ministry of Health Malaysia, one of the standard operating procedure for surveillance activities is the alert mechanism. The alert mechanism for any infectious disease is derived from the various surveillance data system, and should be undertaken by all levels. The alert indicators of impending outbreaks include the action thresholds established at district, state and national levels together with relevant programs, the occurrence of a cluster of disease or deaths related in person, place or time, alerts generated by other surveillance system like the vector density, surveillance-related information from vaccine coverage data, food lab results and other agencies. On the other hand, the mechanism for alerting other relevant parties are divided in the district level, state level and national level, with the respective personnel responsible for managing and informing each level of alert. Another outbreak response is risk communication. Objectively, an effective risk communication functions to prepare every individuals in the health ministry or the center of disease control, in dealing with potential crisis, prevent speculations, prepare every individuals in the health ministry or public health officials, to be ready at all times, and to improve readiness to handle crisis, and to reduce the panic and anxiety among the public.
Alright, do you guys have any questions about my seminar on the surveillance and outbreak management of airborne infections?
Yes, I have one question.
Okay.
Is there a type of surveillance that can actually control the airborne infection from animals?
There is actually. It's called the arboviral surveillance system. It is responsible to do surveillance for sentinel birds, mosquitoes in pools, or dead animals that could potentially transmit airborne infection.
Alright, in the TB case, what is the main surveillance done for TB infections?
The main surveillance done for TB infections are like the tracking of active cases of TB diseases, the treatment of TB outcome, contact investigation, and monitoring the drug-resistant strain of the TB bacteria.
I have another question as well.
Alright.
In the case of airborne bioterrorism case,
Alright.
what can we do to prevent it before it happens?
We could do a routine monitoring for potential bioterrorism agents, like from anthrax to smallpox, botulinum toxin to tularemia. Also, we can also do a follow-up phone and electronic reports routinely to determine if it is in fact a potential bioterrorism agent or pathogen.
Vinny, what's the purpose of risk communication regarding to airborne infection?
It's for the preparation in dealing with potential crisis, to prevent random speculations, and to improve the readiness for us to handle the crisis.
So, Vinny, what are the examples of risk communication?
There are examples like risk communications to individuals and public, like the policymakers, healthcare providers, to make informed decisions basically. And also the media is informed to inform the public on ways to do prevention, prior prevention basically. And it would also be educational to do interactive process of information exchange, opinion among individuals, groups and institutions regarding the airborne infection. have any other questions?
Yeah.
All right, thank you.